I hope everybody can see this. So thank you all for coming today. My great pleasure to introduce, to have today Elizabeth Coulthard from Bristol talking to us about better sleep for brain health. Just some housekeeping, so if you could keep your microphone switched off during the talk, and please keep your video switched off during the talk, and so that everybody has the best experience of hearing Liz talking. Questions and answers. If you want to ask any questions, feel free to click on the chat in your meeting control toolbar. This will open a chat area on the right of your screen, and then you can use this either for comments or suggestions to everyone within the meeting. If you want to ask your question in person, at the end of the talk, just switch on your video, but keep your microphone off, and we will ask you to switch on your microphone to ask your question. And if your questions were not answered, or you want more information, just email us, and or if you're interested to contact Liz specifically, we can connect you with Liz. So the email address, which we put also at the end again on, is just dementia.research@uea.ac.uk. We put that at the end as well in the chat. But it's yeah, my great pleasure now to introduce Elizabeth Coulthard, who's a neurologist from Bristol and an associate professor there at the university. And she's also one of the editors of a very prestigious journal called Journal of Neurology and Neurosurgery. I hope I got this right now. Liz can correct me. But Liz has been working for quite a few years now on sleep as well, and sleep as a risk factor for dementia, and how sleep is also important for brain health. So without further ado, I hand over to Liz, and if you could share your screen, Liz, and yeah, the floor is yours.
Right, are you able to see my screen okay?
Yeah, I can see that, thank you.
Okay. Thank you so much for inviting me to talk. I'm going to talk through some of our research that we've done in sleep, particularly Alzheimer's, but also some in dementia with Lewy bodies. If anything's not clear, I'm absolutely happy to be interrupted. Yeah, I'd rather that than it all be unclear for the whole duration of the talk, but otherwise questions at the end will be great. So the question, what we really wanted to do is to see if we can improve sleep in our patients with Alzheimer's. So I run a dementia clinical service. We diagnose people all the time, and we diagnose people with mild cognitive impairment, the early stage of Alzheimer's, and we're seeing more and more people at the earlier stages. So we want to try and offer tailored interventions to delay decline, and improving sleep may well be something that we can do to help our patients. But as we started thinking about how we could improve sleep, it became really important that we need to be able to measure it. Firstly, to see whose sleep wasn't ideal to start with, and also to measure the effect in trials. So those are the two things I'm going to focus on today. Why are we interested in sleep at all? Well, and we all know that Alzheimer's disease leads to poor sleep. So people with later stage dementia have sundowning, fragmented sleep. It can be a major factor that limits people's ability to live independently, because it's difficult for carers to manage if they're not getting a night's sleep, of course. But that's not really the focus of what we are looking at. What we are looking at is whether poor sleep might actually worsen Alzheimer's. So in the early stages, perhaps before people have symptoms, if you're sleeping badly, is that actually worsening the brain pathology that causes Alzheimer's disease? So that's where we are sitting. That's what we're really looking at. So before we think about poor sleep, I think we have to try and think about what is normal sleep. And actually, that's not all as easy to answer as you might think. So broadly speaking, normal sleep is a period of around 8 hours that corresponds to a period of darkness. But how does it go wrong? Well, sleep can be too short. So insomnia is a well-known sleep disorder, but it can be too short in one clump, or it can be fragmented. People can sleep too much, and that can be in one long sleep or with naps during the day. People can sleep at the wrong time, so they might have an advanced or a delayed circadian rhythm. And on top of these things that we can all report to some extent about our sleep, so duration and timing. When we're asleep, there's a set of brain processes that we pick up with EEG called sleep stages, and people transition through light sleep. So a light sleep known as N1. If someone talks to you, about 50% chance you'll wake up. So quite hard to, that's why defining sleep is quite tricky. But as you go into the next deeper sleep, N2 and N3, that's when your brain starts to oscillate, and the whole brain oscillates together between once per second and 4 times a second, sometimes less than once per second, once every 2 seconds. So these very slow oscillations with lots of bits of the brain all working together in synchrony. And you stay in this deep sleep, and then you cycle out and get into the dreaming sleep, the REM sleep behavior disorder. And you do that several times a night. And as those cycles work through the night, you get slightly more of the REM sleep and less of the deep sleep. So you get most of your deep sleep at the start of the night, but you still get some towards the end of the night. And people can't tell us about these oscillations. So if we ask people whether they had a good night's sleep or not, that will not relate to how much deep sleep they had or how much REM sleep they have. Some people remember their dreams, but some people don't. Remembering your dreams isn't necessarily an accurate representation of the duration of your REM sleep, the rapid eye movement sleep. So this is a world that's going on at night that we just don't know about unless we use EEG. So this is one of the slow oscillations. There's something else I want to point out, because I'm going to come back to it later, is when we have these slow oscillations in the deep sleep, on top of that, a much more rapid rhythm called spindles that sit usually at the peak of a slow oscillation. And these spindles are probably the electrical activity that helps us store memories during sleep. So you have a slow oscillation, and when you have the peak of the slow oscillation, your brain will send some spindles, and that'll be some information conveyed that then sits, rather than being just in the memory areas. Initially it'll sit and then it'll be stored by the whole brain. So within these slow oscillations are these other bits of information that are being sent, and sleep's very important for memory. Right, so our patients have these whole sleep cycles they can't tell us about. And then there are sleep disorders, which are really common, particularly in later life. So restless leg syndrome, where people have the irresistible urge to move their legs. That can interfere with sleep, as can periodic limb movement disorder. So people move after they've gone to sleep and wake themselves up, but they don't necessarily know. And their bed partner may not know, because unless they're woken up as well. Sleep apnea is incredibly common, and in fact I've got a whole other talk on sleep apnea and how we are not picking it up in memory clinics. But if you're in sleep apnea, people's breathing in severe sleep apnea, they'll be woken up at least 30 times an hour, or have micro arousals at least 30 times an hour. And you can imagine that your brain processes your deep sleep will be very much disrupted by that. And then some abnormalities like REM sleep behavior disorder, where people have vivid dreams and they're not paralyzed during their dreams, or night terrors, where people wake up with nightmares. These are all disorders that people may or may not tell us about and might be commoner in our clinic population. So we know that sleep can be abnormal, but why do we think that poor sleep links to future Alzheimer's? Well, there's some epidemiological data. So this came out last year using UK Biobank data, where brain imaging had been performed. And what this shows is, if you look at sleep duration along the bottom here, that both short and long sleep duration, people have reduced brain volume, and that includes in the hippocampus. And the hippocampus is the memory area that we know is affected early in Alzheimer's. So it looks like poor sleep is linked to brain volume in people before they have a diagnosis of dementia. And if we look at the brain volumes affected, as well as the hippocampus, quite a large area of the brain volume actually was dependent on sleep duration. A drawback of these studies, though, is that the way they looked at sleep was by asking people about their sleep duration. And we'll come to it more in a minute, but perhaps people aren't fully accurate when they assess their own sleep duration. So there's some epidemiological data. And then if we look across lots of studies, so with systematic review, see that overall short sleep insomnia gives a higher risk of cognitive disorders in later life. so vast numbers of patients go into all these studies. So we can see that, and there seems to be a sort of protective window of sleep between 5.6 and 9 hours, perhaps, but below 5.6 hours and above 9 hours is associated with a higher risk of cognitive disorders such as dementia. So epidemiological evidence points to sleep predicting dementia. Then there's some clinical cohort data. So I'm going to skip through this quite quickly, but there's a data set called the EPAD data set that you may well have come across, where patients were very deeply phenotyped. And they looked at cognitive disorders not just by a brain scan or by memory tests, but actually took spinal fluid during a lumbar puncture and looked at the markers, the molecular markers of Alzheimer's disease. And they also did subjective questionnaires about sleep. And one of the findings from this was that sleep disturbance at baseline predicted low Alzheimer's markers in the CSF after a year and a half. Now, you might say, well, that's low Alzheimer's markers, isn't that good? Well, not in this case. So in this case of A beta 42, that clumps in the brain and drops in the spinal fluid. So a low A beta 42 means you're likely to have Alzheimer's disease. So sleep disturbance predicted the molecular change of Alzheimer's disease, and that's just been published last year. And in this study, they did, rather than the subjective questionnaires about sleep, so these couple of studies, they actually did polysomnography, so where people wear EEG electrodes and stay overnight in a lab, and they saw that poor sleep, both objectively on the polysomnography and by the questionnaires, predicted cognitive decline, but their measures of cognitive decline were memory tests. So they weren't sophisticated like the biomarker tests, they were memory tests. So it's quite rare to find the very in-depth phenotyping of sleep that you get with EEG and also the very sophisticated molecular pathology of Alzheimer's. So a lot of these studies have one or the other. But there are some mechanistic studies which have started to link the two. So this came out in Brain a few years ago. And what happened was that this is in healthy young participants who aren't producing the A beta 42, the sticky form of A beta. They're producing the healthy form of A beta that doesn't clump in the brain. So these people were woken up during their deep sleep, and what happened was they had more A beta 42 in their spinal fluid the next day. So just one night of having your deep sleep disturbed affects the way that this protein that has been linked to Alzheimer's is handled by the brain and looks to increase it if it's the healthy form, suggesting it's not getting filtered out as it should do. And they also tried waking people up during their during their REM sleep and other times, and that didn't affect A beta. So it looks like this deep sleep where you've got those slow waves is really important for filtering out the toxic proteins that cause Alzheimer's disease. And this is perhaps more persuasive, and this is from Bryce Mander's group in California, and they actually took people at baseline and did the detailed polysomnography, the sleep recording, and looked at their slow oscillations in their deep sleep, and showed that these slow oscillations, if they were impaired at baseline, that predicted accumulation of amyloid in the brain on PET scanning. So PET scanning, you can actually see the sticky proteins in the brain. So they showed that slow oscillations, if they don't have good slow oscillations, you're likely to start to accumulate amyloid. Just to complicate matters a bit more, it wasn't all slow oscillations that predicted A beta plaque deposit. It was the slow oscillations. So the ones that were under 1 Hertz predicted plaque deposit, which when you're entering the world of sleep research and you say, you sort of think, oh, slow, right, I've got it, slow oscillations, they're between about 0.5 Hertz and 4 Hertz. And then it turns out there are lots of different sorts of slow oscillations. And in this case, we're looking at the slow oscillations, so below 1 Hertz. Right, and then there was this beautiful study that came out in 2019 that technically was really brilliant and linked EEG in a scanner. So if you've ever had an MRI scan, you'll know how noisy it is. So just getting people to sleep in a scanner is a challenge. But they found that the slow oscillation on the EEG came first, and then a change in blood flow, and then a change in CSF flow, suggesting that what you're getting with a slow oscillation is because the whole brain is oscillating together, you're getting some movement of blood and CSF through the brain, and it's that movement that will help to filter out the toxic protein. So they actually give a mechanistic route through which slow waves are helping to filter out toxic proteins. Right, so we've got quite a lot of evidence from various sources that poor sleep is linked to Alzheimer's. But what we don't have yet, to my knowledge, I think, is any evidence that if we do a clinical trial, if we improve sleep in people with Alzheimer's, that we, or people who are at risk of Alzheimer's, that we either delay or slow the progression of Alzheimer's disease. So that's what we really want to do. We haven't done it yet. That's where we want to be. But we've had to try and answer a few questions before we get to that point. So one question is, what aspects of sleep should we measure? So we think we need to measure the slow oscillations, but we had a question is, do we really need to measure slow oscillations? Because we can only measure that probably with the EEG, and that involves electrodes on the head. What about if we just measure total sleep time? Wouldn't that be good enough? Because probably if you're sleeping for longer, you're having more of the deep, slow sleep. So we sort of went about this by thinking, well, what do other people do? So we did a systematic review of the literature, and this was led by Jonathan Blackman and Hamish Morrison, who are both in my group. They're both clinicians, and they looked at a vast number of studies, including 17,000 patients, just to look at if people with mild cognitive impairment and early dementia, what have been measured, what in terms of sleep, what have people done in the past? And we were really surprised to find that there was very little consensus. So there were 165 different metrics reported, 62 were mentioned only once and 92 mentioned only once or twice. And this is a major problem with reporting of trials, because if we all do trials and report different things, we end up, it's in human nature, you report the things that look most interesting in your data set, rather than the things that are actually important for brain health. So I think this is signalling to us that there's some sort of problem here with the way that sleep trials are set up. And you can see that there were some things that were reported quite commonly. So total sleep time and sleep efficiency, which is the time of sleep over the time in bed. So how good are you at staying at sleep? And wake after sleep onset, sleep latency, how long does it take you to go to sleep? And sleep disturbances were all reported quite frequently, but nothing was reported in every single study, and lots of studies just reported their own finding. So actually, when we submitted this, we were just going to leave it at that and say somebody needs to do something about this. And then the reviewers came back to us and said, well, why don't you do something about it? Why don't you propose some core outcomes that every single sleep study should report if they're focusing on mild cognitive impairment and dementia? And actually putting together a core outcome set is a very detailed piece of work. And so we're clear that this isn't a definitive core outcome set. But since the reviewers asked us, we thought, well, why not come up with something looking at what's important for brain health? What do we think people should report? And we came up with this prototype core outcome set. It will definitely be changed because led by Sharon Naismith in Australia, there's now an international consensus group meeting to do a Delphi study to try and come up with a core outcome set for sleep and dementia. But this is what we propose and what we will use until there's something better coming along. So you can see that I've split it up into things that you can measure quite easily by asking people, or can you? We'll come to that in a second. So, but it seems, total sleep time, you can ask somebody, how long did you sleep last night? Sleep latency, how long did it take you to get to sleep? And those things in the top light blue box are things you can probably ask people. The next things are slightly harder to measure, but for the first two boxes, we might be able to use actigraphy. So we're probably all wearing wrist-worn devices that measure activity, and you can wear them through day and night, so you can get an idea about some of these sleep measures. And then we'll come on to the bottom box because that's more difficult to measure. Those are the things I talked about before in terms of sleep cycles, things that actually happen while you're asleep that we're not really aware of. So yes, let's think about this top box you can measure by asking people. So there's this questionnaire that we looked at, and it's called the Pittsburgh Sleep Quality Index. There's quite a few sleep quality measures around, and this is a typical one, but it's very widely used. It's validated, it's used across hundreds of studies, but it wasn't validated in dementia and mild cognitive impairment. But we wanted to start to measure sleep in our clinic patients, and we did a study called Dreams AD, where we record all the data from our clinic patients. And so we started this about a year ago or so, maybe, yeah, about a year ago. And we're still collecting data. And also EPAD, you remember the data I showed you in EPAD, they use this Pittsburgh Sleep Quality Index. So Annika Blatters and Jonathan Blackman are two of our researchers in our group, decided to have a look at this data when we got to about 92 people in our cognitive clinic, and also in the EPAD data. The reason why they wanted to look at the data is they'd noticed a few discrepancies. So if you look at if you look at these questions, during the past month, what time have you usually gone to bed at night? During the past month, how long is it taking you to fall asleep? And during the past month, what time have you usually gotten up in the morning? And how many hours of actual sleep? Well, they noticed that some people from our clinic were putting in that they had more sleep than the time they'd spent in bed. And so they noticed a few discrepancies, because there are several measures in this questionnaire, which is nice. It means you can answer slightly differently to different questions. But if you get big discrepancies between these, it does question the validity. So which answer do you take? So what they did, and this is very recent data that we're just preparing and we're going to submit soon. So they came up with 6 discrepancies, and I really think it's worth focusing on the first 2. So reported duration of sleep should not exceed reported time in bed. And it should not exceed the difference between time of sleep and time of final awakening. So those seem to be fairly clear that shouldn't happen. So that's what they looked at. We looked at the EPAD cohort and the first tranche of our cognitive clinic cohort, and you can see that these are 2 quite different cohorts. So our cognitive clinic, the average Montreal cognitive assessment is 21.6. So this includes people with dementia, people with mild cognitive impairments, all comers to our cognitive clinic. But really, we want a tool that works in all comers, because when we first see people, we don't know what disorder they're going to have. So if we're going to assess their sleep, we need to do it in everybody in the clinic population. Where the EPAD cohort, by design, much less affected. There are some people with mild cognitive impairment, but on the whole, it's healthy people, healthy older people. And we've got a slightly gender imbalance. We tend to get more men than women in our clinic, I think because Lewy body dementia is commoner in men, and because we're neurologists, we get referred a lot of that. So the sample's slightly biased in that way. Whereas EPAD is a research study where often it's more women than men volunteer. And people had poorer sleep in our cohort. So you can see the 2 cohorts are different, but we've compared them, but that's not the main aim. The aim is to look at discrepancies. So we were quite surprised to find this rate of discrepancy in the questionnaire that we were using, because we wanted a gold standard test. So what's the particular relevance to us is these blue lines. So the first one is anybody who made an error at all, and 30% of our patients made one discrepancy that meant that one value could not be true. A lot of the time it didn't exceed about half an hour, so the discrepancies were relatively small. But if actually you're calculating sleep efficiency, which is relates time in bed and time of sleep, if you've got a half an hour discrepancy, that could completely invalidate that measure. You can see it's the first 2 discrepancies that I showed you. So it's differences between time in bed and total duration of sleep and time in bed, generally speaking, that was discrepant. And the EPAD cohort had far fewer discrepancies, but still at least more than 10% of people made at least one error. So this led us to be concerned about using the questionnaire. But we're still using it, and we're going to look further into this to try and understand and see what we can do about it. But remember, all those studies, and I've told you about some, were based on questionnaire data in the MCI and Alzheimer's population. It's quite important to caveat all of those, because what we also found is that the discrepancies were worst in the mild cognitive impairment population, and actually quite milder in the more severe dementia, which doesn't make sense. So healthy people don't make mistakes, very severe dementia patients don't make mistakes, but that's obviously because their carers are filling it in for them. It's the mild cognitive impairment group in our clinic who are making mistakes on these questionnaires. So we did another review to look at what other ways of measuring sleep, and actigraphy can measure some of these things, but actually to get to the deeper sleep, you need polysomnography. And this is an illustration of how it's not the most comfortable setup to come into hospital, stay for a couple of nights and wear this gear on your head, and it's quite labour intensive. So to try and come up with a smoother way, and this is work in progress, we set up a study called RESTED, feasibility trial of using these much more comfortable dream bands. There are other forms of band that are available, and we've recruited about 30 people so far. We're also getting people to do questionnaires. They have an app-based cognitive test. We do cortisol and melatonin swabs, and we get them to wear wrist-worn actigraphs. I can't say too much about it because we've not got the full data set yet. We're still recruiting mild cognitive impairment, Alzheimer's and dementia with Lewy bodies, as well as healthy controls. And in our preliminary analysis, in the dementia group, adherence on tasks is very high, 86 to 91%, suggesting people are finding it tolerable. Obviously, that we'll need to look at the data at the end of that, but it looks like instead of doing that polysomnography, we can use this sort of dream band. And I know other people are looking at other things like in-ear EEG, because otherwise sleep research that looks at slow waves, sort of architecture of sleep, will be very difficult. Okay, so how can we improve sleep? Well, we reviewed this literature again. Jonathan Blackman looked at this, and we looked at everything that everybody had done, and there are a huge number of ways we could improve sleep. We could actually wakefulness, what you do during the day, is critically important. Getting daylight, physical activity, avoiding alcohol, caffeine at bedtime, treating medical and then overnight, not having sleep apnea, treating a restless leg syndrome, not being depressed or anxious. All these things may be good treatments, and very few of them, we found, had been tested in even though they may be available, very few of them had been tested in a robust way. So there's lots that we could try here. And what we envisage in the future is that we will be able to measure people's sleep with one of these devices, a headband or an in-ear EEG. We'll be able to come up with a tailored program to try and improve an individual's sleep. So that's what we want to do in the future. You can see this person here has got a reasonable total sleep time, but their 1 Hertz non-REM is a little bit on the low side, so we try and boost that. And there are lots of ways people have thought about doing that, including sound during sleep that's about the right frequency for your non-REM sleep. Actually, sound that doesn't wake you up entrains some of those slow oscillations and is a potential therapeutic maneuver. That's a trial that's being done, but not by us. So this is what we envisage. This is the future. But for the last few minutes, I'm going to talk about an intervention that we've been looking at and we've been doing a clinical trial in. We've been using a drug called levodopa. And if any of you are clinicians, you'll be very familiar with this. Levodopa has been around to treat Parkinson's disease for decades. And many people ask us why we're looking at levodopa. And the answers are really that it was data-driven. So I'll come to that in a second. But in fact, when you go back to the initial trials of levodopa, it took quite a long time to get convincing data that levodopa was actually helping people with Parkinson's. And I think that's a lesson for us all with our current clinical trials, such as the ones in Alzheimer's. It's actually quite difficult to measure neurodegenerative diseases and how they're being affected. Even Parkinson's, where you've got a movement disorder that you can actually get a physical handle on. But one major side effect that some people thought would limit the use of levodopa is sleepiness. So we've known that levodopa interacts with sleep for decades. We know from animal models that dopamine contributes to sleep-wake control and fatigue levels. And the reason why we pursued it is with PhD student John Grogan, who published some of this. To summarize about 8 years of work, we showed that dopamine affected overnight consolidation of memory in Parkinson's, but in a different way to the effect on memory during the day. And obviously the difference between night and day. There are environmental differences, but one major difference is sleep. So we could see in Parkinson's that the timing of levodopa affected the impact of levodopa on memory, and that sleep seemed to be important. And so we set up a clinical trial, and I think I'd love to have a discussion at some stage about the bureaucracy involved in setting up a clinical trial. But the PhD student Hannah here did brilliantly well, because this was a first polysomnography trial that we'd done. We'd run a few clinical trials in the past, but to set up a sleep clinical trial, go through all the MHRA, HRA ethics approvals, we did it in healthy older people, and we were really just asking, does levodopa improve memory through enhancing sleep? And so we gave a single dose, gave it at roughly bedtime, and we did it it was placebo controlled, double blind, order randomized. We gave a fairly good dose of L-DOPA, 200 milligrams combined with 50 milligrams of a dopa decarboxylase inhibitor, which is a standard preparation for Parkinson's disease, but can make people feel sick. So we preloaded everybody with domperidone. So we used this pretty typical drug that's used in Parkinson's, but we gave it to people in a single dose at bedtime. And then we looked at the effect on memory. So we'd always done word lists, and it's very standard word list when people read a word list, and we've shown that levodopa affected word list memory. But in this study, we wanted something a bit more measurable and sophisticated, so we used a computerized word list where we showed people words, and then we asked them a simple question: is this alive or not? So they concentrated on it. And then we tested whether they thought they'd seen that word before at various stages. So this was one of our main outcome measures, was could they remember a list of words as well on levodopa as they did on placebo. And the other outcome measure we used was, we did do polysomnography. So we brought everybody into a sleep lab, we got them all kitted up in all the gear, and we measured their brain waves during sleep in this way. So this was the setup. I've tried to express this in a simple way, and I never quite manage it. But so the word list memory that we did on a computer was a list of 80 words. And within that, we intermingled 4 different lists. But people didn't know they were 4 different lists. As far as they were concerned, they just saw 80 words, and we called them list A, B, C, and D. And then we gave people some levodopa or placebo. And then we reminded them about one set of the words, 120, list A. So they learned 80 words, they took levodopa, they had another word list of 20 words that one of them was repeated, and we called that a tagging. So 20 of these 80 words were tagged, so they were repeated, so a stronger memory trace. So we had the weak memories, which were lists B, C, and D, and the stronger memories that were list A. And then the next morning, we tested how well people remembered list A and B, so the strong and the weak. And then we tested again at days 3 and day 5, list C on day 3 and list D on day 5. So we wanted to look at the rate of forgetting, how that was affected by memory strength. And there are various ways we could have done this, and we had to be pragmatic with our sample size. And there's loads more we could talk about with this, I think, but that's what we did. So we used this linear mixed modelling. We looked at we looked at D prime as a marker of sensitivity, to look at accuracy that takes into account false alarms. So but obviously, if you're showing people something on a computer, they could just say for everything that they'd seen it before. But so they get shown a word that they've seen before, they say yes. If they say yes every time, they'll get 100%, but they'll be saying yes for all the wrong words as well, because we give them distracted words. So we use this D prime measure, which is well tried and tested, to take account of the fact of all the correct hits and the false alarms. We also use dose in our analysis, although everybody had the same dose. What we mean by dose is a weight-controlled dose. So we know that levodopa distributes around the whole body, so the total concentration is dependent on body weight. So we could, in effect, look at the impact of dose in some of our analyses. And this is what we've got. So we've got a very thorough, Hannah's very thorough, our PhD student. She's now a lecturer, but this is the data presented 3 times at day 1, day 3, and day 5. And here you've got the individual data points, box plots, and then this sort of semi-violin plot that shows the pink is the result from levodopa, and green is a result on placebo. And remember, we're just looking here at the week traces. So this is not the repeated dose, this is just the items that were presented once before levodopa, and then again on days, next morning, day 3 and day 5. So if you just concentrate where the only significant difference was, which is the next morning, actually, levodopa reduced accuracy on our word list by almost 20%, and this was fairly robust. And no matter how we looked at it, that's what happened. So I prescribe levodopa all the time to people with Parkinson's. So this sort of alarmed me a bit when we don't warn people about a memory effect of nighttime levodopa, and people get a boost from being on levodopa overnight symptomatically, often because they can't turn over in bed that easily if they've got Parkinson's, and so they get woken up every time they want to turn over. So we prescribe it at night all the time. So initially this looked, like essentially levodopa was worsening memory or increasing forgetting, and this was weak memory traces only. And also the other slightly reassuring thing is that by day 3 and day 5 there was no difference. So we think of this as accelerated forgetting due to levodopa, but that once you get to day 3 and day 5, you're where you would have been anyway. Obviously, this is a small study, but we can look into this a bit more, but this is what we showed. Then remember that those strong memories, so the tagged ones that were information, people were reminded of information just after they'd had the levodopa. Well, in fact, that showed the opposite pattern. So what levodopa did was worsened memory for weak traces, that was significant, slightly, non-significantly increased memory for strong stages, for the strong words. And so it changed the bias, it increased the bias for recalling prominent information. Now, this needs looking into, but it's kind of in keeping with what you might expect dopamine to do, given the fact that dopamine is involved in reward systems and neuromodulation. Biasing memory towards stronger information seems perfectly reasonable. So that's what we think probably was happening, that rather than just impairing memory, that there was a bias. Levodopa changed the bias in our memory. And part of what happens during sleep is pruning of memories. We can't take on board everything that's happened to us during the day. We start to contextualize things and semanticize to some extent, and so we envisage levodopa having a role in that, perhaps in this, but obviously this is hypothetical and post hoc. Okay, so those are our memory results. What about sleep? So another PhD student who's nearly finished, called Will Carr, he looked at we staged sleep in the traditional way, manually, by going through every page on the EEG and marking the slow oscillations. And we get a couple of people to do it to check that we're not making mistakes. And we found actually levodopa increased the duration of slow wave sleep. And if you remember, this we were looking at that there's a very strong link between that non-REM sleep and Alzheimer's pathology. So we started to think, well, perhaps levodopa is having an effect that could be perceived as beneficial. I mean, I don't know, it's just doing what it's doing here. And we then looked at the spindles. If you remember those smaller waves that nestle on top of the slow oscillations, and we found the dramatic result, which was one of our secondary outcomes, but that we increased spindle amplitude with levodopa. And then we looked back. Do you remember that difference between strong and weak memory traces behaviorally correlates with the change in spindle amplitude? So it looked as though levodopa was either having an effect on spindles, and that in turn had a behavioural effect on memory, or that the behavioural effect directly on memory then affected sleep. We don't know which that is. One question we asked ourselves is, we know that these spindles, the synchronization with the top of that slow oscillation is really important. So when you're young, your spindles are nicely sitting on top of your slow oscillation, and they go a bit to the left, as it were, on this picture, when as you get older, and that correlates with poorer memory. But actually, levodopa didn't affect synchronization at all, and this is just the data showing that essentially what the spindle amplitude was increased, and it was increased at the peak of the slow oscillation, exactly where exactly where the peak of the slow oscillation of the spindle didn't change relative to the peak of the slow oscillation. So it just looked to be effect on spindle amplitude. Okay, so coming to the end now. So in summary, levodopa seems to, well, a positive spin, it increases efficiency of forgetting weakly stored information, improves storage of repeated information, increases duration of slow wave sleep, and increases spindle amplitude. It's a very cheap and tried and tested drug. We prescribe it all the time. And so we felt we had to go on to look at whether or not this could prolong non-REM sleep in people with early Alzheimer's. And this is funded by Alzheimer's Research UK. We've got the ethics approved. We've got MHRA approval. We've got the kit. We're about to start. Just the setup of these clinical trials is enormous, and it's being run by Jonathan Blackman. It's part of his PhD, so we will have data on that in the next year. We're using home polysomnography, so we don't want to bring people into the lab if you can possibly avoid it, but we want the detailed microarchitecture. So we're going to try with these caps at home, because one of my colleagues called Matt Jones, Professor Matt Jones in Bristol, has done this in Parkinson's. Got really good looking sleep data from these caps. So we're going to do it in Alzheimer's, and so we've had some training. We're going to go into people's houses, put the cap on, give them a drug, go home, and then we'll be in contact with them and we're remote monitoring their sleep, and then we'll be back the next morning. So hopefully they get a better night's sleep after being tucked in by one of our researchers, rather than having to sleep in a sleep lab where they know they're being video monitored and they're in a funny hospital bed, etc. Right, so this is the end. I think the epidemiological and mechanistic links between sleep and brain health are really convincing. But we've got a mountain to climb to try and determine which home technology we should use, how we should measure sleep, who we should target, and what interventions we should use. And that's really what my group is trying to do. And here they are at World Sleep, and this is some of our funders. So I'm going to stop there. Thank you.
Great, thank you very much, Liz. That was a brilliant overview of what you're working on. So thank you so much. Now, if you have any questions, please put them in the chat or come on the video if you want to and ask your question. While people think about it, I might kick us off. So it was really interesting about your core outcome set. I think that's really, really interesting, isn't it? How people actually how different things they measure. I wonder, how does the core outcome set apply to your L-DOPA data, I guess?
Yeah, okay. So we did that. That's oh gosh, I'm being hoisted by my own baton. Yeah, so yeah, so obviously we hadn't really thought about the core outcome set where we've and the spindle amplitude. We did have a priori hypotheses about memory, which wouldn't fall into the core outcome set anyway, and about non-REM duration, which is in the core outcome set. But the spindle amplitude, really, that was post hoc, and we looked at spindles. We looked at spindle density, which is the thing that's most commonly cited as related to memory, and we looked at amplitude as well. And it's just the result was quite striking. And also, the other thing, I mean, just for full disclosure, we don't really have a model for how spindle amplitude links to memory, and maybe somebody somewhere does, but we've sort of tried to talk to people about modeling it, and maybe they can, but we don't really know. So yeah, you're right. We didn't.
No, it's interesting, isn't it? Because this is the dilemma between the more basic measures, which maybe more people can use, and the more sophisticated measures, obviously, which might give you more information, and then looking at cross studies. That's really fascinating, I think.
Yeah, so I think with the core outcomes set, one thing to say is that we didn't envisage it being the only data anyone could ever report.
No, of course not.
We thought that if everyone had all that in there, because when you come to meta-analyze, it's actually quite tricky unless you've got the core.
Exactly.
Yeah.
So we have a question here from Cindy, or Shireen, sorry, I don't know. In your suggested measures for future trials, how would also ensuring that measures the use of hypnotics and other potential confounding factors such as depressive symptoms, alcohol, perhaps also standardized such assessments. What do you think?
Oh, so that's a really good point. So actually, I didn't show the second bit of the PSQI, which I quite like as a questionnaire because it does have questions in there about drug use of hypnotics, and there are some standardized depressive. I don't know, because I'm going to join this Delphi panel, but I don't know. Actually, I hadn't really thought of that. Whether we should include in there a marker of depression. We know depression and anxiety are so tightly linked to sleep that's probably a really good idea, and certainly the use of hypnotics should be in there, I think, as it would be if ideally we'd have something version of the PSQI that was suitable for memory clinic patients. And
yeah, no, it's a great question, isn't it? Any other questions or points people want to raise? Please feel free to come on. I guess the other thing, yeah, it's really interesting, your L-DOPA findings, so which is quite, you know, as you say, it's quite tricky to unpack, isn't it? How whether the stronger or weaker memories are more fostered by actually the L-DOPA, which is really, really interesting. Why do you think that might be about the weaker memories? It's of course speculation, but do you have a reason why it might not help with the weaker ones?
Yeah, so there's the synaptic tag and capture model, which so there's a molecular explanation for how dopamine enhances certain synapses, because they're tagged for memory. So that we can understand that. There's another explanation, and the way we set our experiment up doesn't differentiate these, which is very frustrating, but you can only do, you know, this is what we set up at the time, we didn't, which is retrieval enhanced forgetting, so that if you retrieve one memory from a selection, you'll automatically suppress the others, and that's been behaviorally shown a few times. And at the moment we can't, I mean, so levodopa could have a role in that system of retrieval enhanced forgetting, and we can't differentiate. The next study, we're kind of taking the memory test out of the equation. We're just asking what is the impact on sleep of levodopa in a very clinically pragmatic way. But I'd love to do a whole set of, like trying to get funding to do a whole set of behavioural experiments to really understand what levodopa is doing. I'd be fascinated in that, really.
Great. And Silvana is asking, how do we explain people with Parkinson's disease who take levodopa and also have sleep disorders?
Yes, so I didn't go into this, but Parkinson's is associated, I mean, with something called REM sleep behavior disorder, and that predates the onset of Parkinson's by many years, into decades. And levodopa doesn't really affect it, to my knowledge. So it's a disorder that's a feature of the neurodegeneration and not necessarily dopaminergic. And so we wouldn't expect them to use of levodopa to affect that, and also we don't expect levodopa to be the defining treatment for Parkinson related sleep disorders. People with Parkinson's have huge anxiety often, and that can interfere with sleep, and we wouldn't expect levodopa to affect that. So I think with all patient disorders, you've got a variety of factors affecting sleep. And one interesting question is whether people with Parkinson's on levodopa might have lower levels of amyloid, because amyloids are co-pathology often, and we haven't looked at that, so we don't know.
And then we have a question, could you compare and contrast subjective sleep of the PSQI to the actual objective EEG measures?
Yes, so that has been done, so we can do that in our RESTED study that we haven't got the data from, and people have looked at that in healthier populations, and I mean it's already known that there's a systematic bias. So people's anxiety and depression will, as we just mentioned, have a huge impact on their perception of their own sleep duration, and particularly things like fragmentation people don't have an idea about. So yes, that we already knew that that these subjective measures were going to be impaired, but we thought that they'd correlate well enough. But if in fact the problem is with people filling in the form because they've got a cognitive impairment, then that's an extra layer of inaccuracy.
Yeah, that's a really great question. So, and then another question by Kelly: what factors or prognostic variables was the linear mixed models adjusted by?
Well, it's been a long time since we did it, but I think I think not many. I think age was in there. Obviously we had body weight to calculate the dose, well, I can send you a link to we've got the preprint published, and we might be getting close to publishing the actual paper soon, so I can send you a link to that. But was there anything that you were thinking of, because we we're still looking at it, but we didn't use any prognostic variables. So this was a group of healthy older people, and they were generally pretty fit older people. Got an amazing response from people wanting to come and take part in this overnight drug trial. Yeah, I think, does that sort of answer what you say?
Let's see if Kelly comes back. I just want, oh yeah, yes, thank you, she says. Okay. And in terms of genetic risk, I guess ApoE, everybody asked about ApoE. Did you have a look at that? I guess you didn't recruit for it.
Yeah, we didn't have a look, and it's really difficult, because if you look in the current NICE guidelines, ApoE is not, it says do not test for ApoE in dementia clinics. So clinically, we haven't instituted it, and therefore we haven't probably got it's been pretty easy for us to do it in research. We did it in EPAD, obviously. We sent it, but I think that we should start that, and plus the ApoE4 status and possibly the polygenic risk score, and because it looks like the biology, particularly now we're starting to give the well, in research we're giving the lecanemab, and lecanemab might be licensed. It looked like ApoE4 might define some of the side effects from that. So I think it's something we're going to have to introduce, I think.
And Russell has a question: how would historic sleep patterns affect any sleep studies, such as shift workers, people, and when they were in employment, work nights, as the sleep patterns tend to remain with people over time? Yeah,
and so there is reasonable epidemiological data that being a shift worker is bad for your future brain health, unfortunately. Bad for those of us who went through being a junior doctor, but hopefully, if you only do that for a few years, it's all right. But we do take a history of shift work. We include it. It's in some of the questionnaires. We've not had enough people who are shift workers in our work to draw any conclusions yet. In RESTED, we'll wait and see. I'm not sure how many shift workers we've got there, but we're doing their cortisol levels and melatonin markers of circadian function. So we'll see if they're blunted, and if there's a certain group in which they're blunted.
Yeah, absolutely. That's a kind of a key factor, which, as you said, is long known, that shift workers are at increases, but for lots of different neurodegenerative diseases, not only for dementia, I think, if I remember correctly. Great. I think we're coming to the end of the hour. So are there any further questions? It's your chance. Or come on screen. If not, I put in, again, in the chat, just our email address if you want to email us. So if you had any questions which weren't answered, or you wanted to have maybe a connectable list for anything. And also, if this meeting was recorded and will be uploaded as always on our website, but again, you can email us. Oh, Jaden has a final question: are there differences in cognitive function that result from sleep disturbances due to psychological or physical pain?
That is such a good question. So these questions are all really good, and every time I get questions like this, I get my research gets a little bit better and more convincing. So thank you for the questions. I have got no idea. That's with them. Somebody may know, but I do not know the answer to that. So sort of depressive levels versus pain. I mean, obviously the two are linked, but that would be very interesting. Yeah, I don't know.
Yeah, chronic pain, of course, very common as well.
Yeah,
so that would be really interesting. Great question. Right. I think then, just before we thank Liz, I just to highlight that our next meeting is on the 27th of April. So if you're on the email list, please, you will be informed anyway. But if not, you can email us as well to be put on the email list. And thank you again, Liz, for great talk. Really fantastic. Thank you for coming over, and thank you all for coming. And hopefully see you next time.
Thank you. Thanks for inviting me. Thanks. Bye.
Thanks, Liz.